And so I will be restricting the talk to use in hepatology only, because there are multiple situations where ammonia can be used, and I'll not be covering those for the want of time. So the outline of my talk will be the role of ammonia estimation in liver disease, in acute liver failure, where we have the most evidence, and then in cirrhosis, where the evidence is rapidly evolving. We'll then talk about how it is useful in risk stratification and how it correlates with outcomes, which now we have a wealth of evidence on. Then we'll get a little more harsh, because see, we know that ammonia has a central role in liver disease, but does it actually affect on ground individual patient clinical decisions? Then we'll talk about what are the issues with ammonia estimation and false positives, and then we'll boil down to the final clinical implications. So let's first start with acute liver failure, where we all know that ammonia plays a major role. How it works is, now nitrogenous metabolism, ammonia is a common byproduct, which in the absence of hepatic function, that is in the presence of liver failure, there will be hyperammonemia, which will lead to neurotoxicity by way of, first of all, the osmotic astrocyte swelling, because the ammonia will be taken up by the astrocytes, which form approximately 25% of the brain volume. And it will be trapped as glutamine. It will eat up the glutamate, get trapped as glutamine, cause osmotic damage. Thereafter, in addition, it will go into the mitochondria. The ammonia will be deaminated, the glutamine will be deaminated in the mitochondria. It will cause direct mitochondrial toxicity, oxidative nitrosative stress, leading on to inflammation, neuroinflammation, senescence, cell death, autophagy inhibition, mitochondrial damage. All of that ultimately leads to a situation where we have neuroinflammation and hyperammonemia, in addition to the ongoing systemic inflammation, and the major killer for acute liver failure, that is increased intracranial pressure that may lead to coning. This is the major difference between acute liver failure and cirrhosis, where we have raised ICH because of absolute pressure symptoms. So we've known this for a long time now, that ammonia levels that were high were correlating well with cerebral herniation. And this is one of the earliest studies for that. However, we also need to keep in mind that while it was good at predicting which patients were, this was retrospective, and which patients actually had cerebral herniation, there was a potential for misclassification. But then this very nice study came out of King's College, where they actually looked at patients who had higher grades of encephalopathy in acute liver failure, had higher levels of elevated arterial ammonia. This is the group. And they actually looked at, did baseline hyperammonemia, even in the absence of encephalopathy, predict future development of encephalopathy? And sure enough, it did. These are patients who did not have encephalopathy to start with and were finally diagnosed with acute liver failure. And we can see that patients who had ammonia more than 100, they often developed encephalopathy later. When they used lower cutoffs, even still many patients did develop encephalopathy. So ammonia was an independent risk factor for development of both HE and intracranial hypertension. But important thing that we need to again see here is, there was, even if the ammonia was normal or near normal, let's say less than 75 or less than 100, it was not good enough to rule out development of encephalopathy. And as we discussed, for clinical decisions, we'll have harsher parameters. Is an investigation able to rule in, rule out, or clearly prognosticate? And that metric was probably not met at this stage. Now let us look at data from India. Now from India, most of the data has actually come from AIIMS, where beautiful studies have been done on the use of ammonia in prognostication of acute liver failure. And again, we can see that with good reliability, survival could be predicted with ammonia. And this very brilliant study that came out in 2012 on the dynamic use of the ALFED model, where if you looked at persistence of hyperammonemia at day 3, it was able to very well predict which patients are going to not survive. And this was the best part of this study, where actual on-ground observed versus predicted calculations were done, and the derivation and the validation cohort actually matched very well. Unfortunately, this study was in a non-transplant setup, and in this day and age, most of the ALF data that we talk about is going to have to be validated in a transplant setup. So this is probably the only drawback which is precluding us from using ammonia more and more in patients with acute liver failure for clinical decisions. So as of now, despite this brilliant data, we still use King's College as the main criteria because most centers would not want to wait for 3 days for prognosis estimation. So to summarize the role of ammonia in acute liver failure, it correlates very well with intracranial hypertension and outcomes. It does predict very well non-transplant survival even in individual patients. Unfortunately, not validated in a transplant setup, and with the currently available data, it rarely informs our clinical decisions over and above the normal clinico-biochemical assessment. And that is probably why routine testing has not been recommended by any major guidelines. So let us now come to cirrhosis, where lately there has been a lot of data coming in. Now we know that in patients who develop cirrhosis, there is an additional component of portosystemic shunting that leads to increased ammonia delivery to the brain and gut-derived toxins going into the systemic circulation, leading on to neuroinflammation, development of pseudoneurotransmitters, and systemic inflammations. They all contribute to the cognitive problems. So it is not just hyperammonemia which is primary driver in acute liver failure. Here there are many more things that come into play more dominantly, and as a result, even though there is cerebral edema, this cerebral edema is not causing intracranial hypertension, and that is why this is a much more subtle form of encephalopathy. So we've had 3 major studies that have told us about the use of ammonia in diagnosis of hepatic encephalopathy. And based on these 3 studies, actually most of the data has come up, but let us look at the nuances of these studies. Now, this is one of the older studies from Italy, where they talked about partial pressure of ammonia, arterial as well as venous ammonia, and they saw that patients who had encephalopathy did have higher levels of ammonia. However, the levels were not as starkly different. You can see that there's a lot of overlap in the confidence intervals, and that is why the authors primarily, they said that even though ammonia can be used and arterial and venous ammonia are both similar, all 3 determinants had limited role in the diagnosis of encephalopathy. And here we can see that even when they followed the patients up, even the very high ammonia levels actually came down over time as the HE resolved. If you look at the ammonia levels that were around 200 to 150, they did not really come down as much. So again, at that time, the efficacy was thought to be limited. And then let us look at more granular data. This is another major study that again is about 2 decades old, where again we can see that even grade 0 and grade 1 and grade 2 HE, they have a very very overlapping 95% confidence intervals of ammonia levels. So both arterial and venous ammonia, while they are showing us a very clear trend, if it boils down to actual diagnosis, they are probably not going to be very helpful. And let us look at this study. This is another major study where again we can see there's a lot of overlap, and here they very clearly showed us that even with low grade and even high grade encephalopathy, a great proportion of patients actually had normal ammonia. So, and even with low grade HE or no HE, there was a substantial proportion of patients who actually had raised ammonia. So again, when it comes to dichotomous diagnosis, that is, does it rule in, does it rule out, while there is definitely a trend, it is not performing as well as we would like it to be. But is encephalopathy the only metric in cirrhosis? Well, probably not, because we now know that ammonia is important in sarcopenia, immune dysfunction, hepatotoxicity. Even for NASH, there's more and more evidence that ammonia plays a major role. So how does ammonia do in terms of clinical prediction? This large study with a long follow-up came from, again, from the European groups, where they saw that there was a good predictive value of ammonia for liver-related complications. But again, the area under curves are not stellar. Its area under curve is 75 to 80%. This is another study which came out from, again, from the European cohort, Dr. Rajiv Jalan's group, where they actually looked at long-term outcomes, and patients who had high ammonia levels to start with had poorer outcomes. Again, however, these are the confidence intervals quite overlapping. study from India. This was actually a multicentric study from UK and from India, where patients who had intermediate grades of encephalopathy. So this is grade 1 to 2 HE, and this is grade 3 HE, if I remember correctly. There was a lot of difference in the levels of ammonia. If these patients had low ammonia to start with, even if they came with a reasonable degree of encephalopathy, they probably did better. But patients who came with deep encephalopathy, it was irrespective of their ammonia levels, that their outcomes remained similar. So again, there's more data from Indian group, the ACLF consortium, where the grade of encephalopathy was fairly dependent on ammonia levels. However, it was not, the sensitivity and specificity were in the 70s and early 80s. So again, when it comes to dichotomous clinical decisions, it did not do as well. Now let us move on to the bedside. In the real world, the ammonia levels really did not correlate very well with clinical outcomes in the sense that decision making did not really change, and there was a lot of individual and intra-individual variability, and this was shown in multiple studies. With a 20-gram standardized protein meal, there was a lot of variability, and even when ornithine phenylacetate was used to target hyperammonemia, no significant difference was seen in time to clinical improvement when ammonia scavengers were directly used. So the good and the bad and the ugly. The bad and the ugly are that it is not correlating the levels. While they are correlating very well with cohorts, they are not very well correlating with individual clinical decisions. And so until now we know that it correlates well but with outcomes, but does not really do well in individual clinical decisions, even in highly optimized research settings. In the real world, arterial, venous, capillary ammonia, every center does it differently. There are different cutoffs. Collection issues are rampant. The sample has to be fasting, it has to be taken on ice, it has to be analyzed within 20 minutes. Amount of protein that has been taken has to be standardized. Tourniquet changes everything. So there is a lot of lability. So considering, and all of these causes of hyperammonemia have to be considered in our patient population. So that is probably why most guidelines have a very guarded recommendation and with a low level of evidence of use of ammonia in clinical decisions. So to summarize, ammonia has a central role in the pathogenesis of HE as well as in cirrhosis, and it does predict outcome in acute liver failure as well as in cirrhosis. However, the testing and interpretation is logistically challenging, even in research centers, and it does not translate very well in the routine clinical practice. So while it is an excellent research tool and tells us a lot about cohorts and trends, it, I would say, has limited applicability in individual clinical decisions. So it's not a test that should be routinely used in all patients. Thank you.
Thank you, sir. It was very nice talk, and we can have some questions from the audience, from the house.
Dr. Sai?
Yeah, please.
Do you think it has a negative predictive value in patients of liver cirrhosis?
Yeah, so I think that's what the EASL guidelines also say, and ASLD also gives a guarded recommendation on that. I would say that, as I showed you the raw data based on which the recommendations were actually generated, if you look at the raw data, the granular raw data, where they have beautifully shown with dots individual patients, there's a lot of overlap. So, I mean, I would say that if we have a patient who we have treated for encephalopathy is not showing improvement, maybe a normal ammonia level should trigger us to look for other causes, which I would argue we should look for anyways, because encephalopathy, hepatic encephalopathy in a patient with cirrhosis should be a diagnosis of exclusion. Every other possibility, every other precipitant should anyways have to be ruled out. So that's what I would add.
And what was the reason you have shown a higher level of ammonia has a greater correlation with the encephalopathy in acute liver failure and not that much correlation in chronic liver failure? What do you think?
So in chronic liver failure, the level of encephalopathy is not purely dependent on ammonia. There's a lot of other things that come into play. The neuroinflammation, systemic
They are
inflammation.
also coming ALF also. Those all things. Metabolic.
You are absolutely right. But in ALF, hyperammonemia and resultant intracranial hypertension because of osmotic astrocyte swelling is the major is a major player in deciding the level of encephalopathy. In addition to while in cirrhosis, that role is not probably as much as other factors.
Thank you.
Thank you, Dr. Rati. This is Dr. Ilan from Apollo Chennai. So, one question regarding ammonia in clinical decision making, especially in the setting of acute liver failure. When these patients have very high ammonia levels, how strong is the data to put them on a CVVH as a prophylaxis to avoid?
So I think we now have a reasonable amount of data coming in from multiple studies, in addition to the Finn Larsen's trial from 2015, where they actually showed mortality benefit in a RCT setting. We also have a lot of observational data, and in our own experience, we do feel that plasma exchange and CRRT do really help in patients with hyperammonemia. However, if you ask me regarding strong data, I would say that the strength of data right now is limited. Hopefully the ongoing studies will tell us. I mean, in my personal experience, I do believe that it does help. However, if you ask me about strong data, we don't really have strong data of ammonia directed CRRT and Plex in a randomized setting.
Preference for either one of them if ammonia is high, plasma exchange or CRRT?
So I think plasma exchange, we would always want to prefer plasma exchange.
I think we can now move to the next session. Thank you, Sahaj. Excellent talk.